Dr. Christine Gosh. I'm an emergency medicine physician. I'm working in Branson at Cox ER and in Harrison, Arkansas, North Arkansas Regional Medical Center.
What are some positive things about the emergency department?
Oh, it's nice to have lots of variety, to not know exactly what you're seeing every day, and for a part of the care to have everything be kind of exciting. And it's also something that we're doing a lot of good for a lot of people. It's nice to be able to serve some of the people that are underserved in the community.
What are some negative things about it?
Some of it is the variety of shifts, working bad hours, but that is just part of the ER role. But bad things that's changed over the last 10 years, access to health care and the trends in society have affected the volume and the collection of patients that we see, and it's made it a lot harder to work with.
What are your thoughts on how the emergency department is misused?
I think probably about 50% of the patients that we see probably don't belong in the emergency department. A big part of that is the drug use has made it so people want to come and try to get pain medicines. Also affects the type of patients that we get, so they're coming in with drug-related problems. And another big factor is access to healthcare. People not having insurance, having Medicaid, and having doctors that won't take new Medicaid patients, as well as elderly people that just can't afford to go anywhere, and people that just don't want to wait for an appointment. They call to get in with their primary care, and they tell them it's going to be 6 weeks, and so they just show up in the ER.
What do you think contributes to the misuse of the emergency department?
A big part, I think, is the drugs, as I said. I think the way our society has developed into I want it now sort of mentality. They don't want to wait, that they just want to come to the ER and get everything taken care of. And a lot of the times they don't have to pay for stuff up front if they don't have the money, so they can just come and get what they want. Kind of like going through the drive-thru and buying off the dollar menu. You just show up and you're getting taken care of.
How does the overuse of the ER affect the working environment?
It's frustrating for many of the staff members. Some of it increases our volume, so there's a lot of people in the waiting room waiting to be seen that really probably don't need to be in the ER. Those people are oftentimes very angry and impatient, and they repeatedly bother the staff, and it becomes really overwhelming how they treat you. And then of course when they come to the back finally after they've waited a few hours to be seen again, they're very angry, so you start out with a bad relationship right off the bat with those patients that have waited a long time. It also makes our volume so much higher that our workload oftentimes is really unsafe patient ratios. It makes a lot more social work, and we don't have a social worker all the time, so those people that don't have insurance or that are homeless or that have overdosed on their medications, we often have to spend hours looking for places for them to go and resources to help them get the care that they need. So overall, it just emotionally it just increases the stress load of everybody in the ER, so it makes the working environment oftentimes really it's almost explosive.
Is Cox Branson doing anything to help the patient overload?
We do have a social worker there for 12 hours each day, and during the week, not during the weekend. Then we have somebody on call, and we do a lot of referrals for follow-up to make sure that people have a primary care physician to follow up. If they don't have resources, we do have a couple of free clinics that our social worker is fantastic about getting those people hooked up with, oftentimes same-day appointments, get them there and they'll get them their medications. So we are doing a lot of things as far as that goes. There's a big void in the system with the drug population, and we did have a rehab center, but that's recently closed, so we do have a little problem with that. So we are working on that. That's really what we're working on right now.
What's a big difference between working in Mercy and Springfield to Cox Branson?
Well, I spent 16 years at Mercy, and my first 10 or so, probably 10 to 12 years, was just kind of normal volume. And like I said, over the last 10 years, things have drastically changed to the point that now at Mercy, oftentimes there's a 10-hour wait, sometimes there's 25 to 40 people waiting in the waiting room, and we have all the beds full, and many times 10 to 16 hall beds. Oftentimes as a physician we would be carrying 12 to 14 patients at once, and it was a disaster. You didn't know what was happening with all those patients in the waiting room, and they're very angry, and people are sick and they can't get back, and it was just an overwhelming work environment. And in Branson, it's kind of the same issues, but in a much smaller degree, and it's easier to digest the fact that maybe there's 10 people out front that have waited 2 hours versus 40 people that have waited 10 hours, and it's just a much less stressful work environment to have that be a smaller capacity.
What about how they bring the patients back? How is it different from Mercy and Branson?
At Mercy, we did what's called direct bedding, and oftentimes the techs would just put them in a bed, not even put them on the monitor, and they wouldn't have had vital signs done, and the nurses were so overwhelmed they couldn't get to them. And so oftentimes those patients sat there for hours before we would get to them and know what was going on, and it's just a scary situation to have it be like that. In Branson, almost everybody gets at least an initial triage by the nurse, even if it's just a short. We do occasionally direct bed if the nurses are not overloaded, but we also have a maximum capacity where the nurses have to have a dedicated number of rooms that they're assigned to, and they can't be overloaded unless it's an absolute emergency.
So you would say that the way Mercy does it puts the patient at risk?
I do. I don't think that it's their fault. I really think it's just the volume of the ER. It's just and it's every big hospital in the area. They are just overwhelmed with the people, and many of the people that sit in the waiting room for 10 hours don't need to be there.
The Institute of Medicine suggests that the emergency room has become a so-called safety net. What are your thoughts on that?
I do think that's probably an appropriate term. Everybody, and it's kind of like the all of the people just end up in the ER where they're just dumped on us. And whether they don't have insurance, whether they can't pay their copay, whether they're on Medicaid and don't have a primary care doctor, whether they're on drugs and they can't get off, homeless. Sometimes it's people with insurance, but their primary care doctor send them to the ER. All those people we have to see and figure out where to put them all. So you've got a homeless person that needs to be placed in a shelter. You've got a drug addict that's in withdrawal and they need to be sent for rehab. You've got some little old lady that can't afford her medicine, and so you got to try to figure out how to get her medicine. You've got somebody that's really sick and they need their medications and they can't afford them, and figure out how we're going to get those. And people that don't have a doctor, how to get them a primary care doctor. So all the time, we're not just doing patient care, taking care of patients. We are doing all these networking outward things, trying to figure out how to get these patients somewhere else. And oftentimes those patients sit in the ER holding beds while we're trying to figure that out.
Could you sum up the overall effects of the misuse of the emergency room?
I really think that having too many patients and many patients that are inappropriate for the ER and inadequate resources, it just has an exponential effect on so many factors. Just kind of walking through a day, if I walk in the door and there's 20 people sitting in the waiting room and there's 4 or 5 standing at the triage desk, I immediately feel overwhelmed and think, oh my Lord, this is going to be an awful shift. And that already is going to be factored into the staff that's there. You go back, everybody's busy, there's no place to put anybody, can't get people out of the ER, so the nurses are angry, the physicians are overworked and frustrated, there's no place to get the drug addicts someplace, so we all really get overstimulated and overworked the whole time we're there. We go home angry, so we take it out on our families. And then there's all of the effects on all the patients that don't have a place to go, or don't have medical care, or can't get into their doctor, or they can't afford their health insurance, so they come to the ER. It's so exponentially effective on all parts of life.